As a brain doctor, I'm going to say something that might make you walk to your medicine cabinet the moment this video ends. Some of the pills most people keep for sleep, allergies, nerves, overactive bladder, pain, or muscle tension can quietly blunt attention, slow learning, and speed up memory decline, especially after 50. I'm not saying this to frighten you for clicks. I'm saying it because the science is consistent, the pattern is common, and the fix starts with awareness. Before we dive in, 2 promises. First, I will never tell you to stop a prescribed medication on your own. That's dangerous. What I will do is teach you what to look for, the questions to ask, and the safer swaps to discuss with your clinician. Second, I'll explain the why, the brain chemistry behind these risks. So this isn't just a list, it's a plan you can act on tonight. Here's the big idea. Your brain uses a messenger called acetylcholine to encode new memories, keep attention steady, and help nerve cells talk to each other efficiently. Many drugs block this messenger to varying degrees. These are called anticholinergic medications. A single dose may make you sleepy and forgetful for a day. Long-term or combined use can add up to what we call anticholinergic burden, which is linked with worse thinking, confusion, falls, and in some studies, accelerated cognitive decline. On top of that, other drug families can sedate you, disrupt sleep architecture, cause oxygen dips at night, or trigger depression and apathy, all of which injure memory in a slower, quieter way. The key is not panic, the key is pattern finding. If your memory feels less sharp, if you're foggy in the morning, if loved ones say you repeat yourself, and if your cabinet contains one or more of the categories I'm about to describe, it's time for a thoughtful, supervised cleanup. Let's start with the one I see most in kitchens and bedside drawers. First-generation antihistamines hiding as sleep and allergy aids. If your label says diphenhydramine, doxylamine, chlorpheniramine, brompheniramine, or similar, you're holding a strong anticholinergic. Brand names include things like Benadryl, Zizquil, Unisom, the doxylamine formulation, and many multi-symptom cold remedies. People love them because they knock you out. They do by blocking acetylcholine in your brain. The price is next-day grogginess, slower reaction time, and poorer short-term memory. For some, the effect lingers for days. If you find these in your cabinet, do not toss them in rage. Write them down, circle the active ingredient, and talk to your doctor about non-sedating allergy options such as cetirizine, loratadine, or fexofenadine, and non-drug sleep strategies like better sleep timing, light control, or a very low-dose melatonin trial if appropriate. The point is to stop using brain-blunting sedatives to treat problems that have safer fixes. The second place I find trouble is in the bathroom, overactive bladder medications. If you see oxybutynin, tolterodine, solifeninin, dariphenacin, fesoterodine, trospium, or anything that says antimuscarinic on a pharmacy sheet, these are anticholinergics designed to relax the bladder by blocking the same messenger your brain uses to remember. For some people with severe symptoms, they're appropriate under close supervision, but for many older adults, they are absolutely brutal on thinking. Common side effects: dry mouth, constipation, blurry vision are red flags that the drug is reaching your brain. Don't suffer in silence, and don't quit cold turkey. Ask your clinician whether a non-anticholinergic option like mirabegron or Vibegron could work for you, and whether pelvic floor therapy, bladder training, or timing your fluids before bed might reduce symptoms enough to lower the dose. Third, certain antidepressants have a hidden cognitive toll. The tricyclics, amitriptyline, imipramine, nortriptyline, doxepin at standard doses, and their cousins, were breakthroughs decades ago, but they come with strong anticholinergic effects and heavy sedation. They're still prescribed for nerve pain, migraine prevention, sleep, and depression. If you wake groggy, if your mouth is like sandpaper, if getting out of a chair feels like lifting a boulder, your brain is telling you the cost is too high. A thoughtful taper, coordinated with your prescriber, and a switch to alternatives with lower anticholinergic load, such as certain SSRIs like sertraline or citalopram at careful doses, SNRIs like duloxetine for combined pain and mood, or migraine-specific strategies, often improves clarity without sacrificing relief. There's also a special mention here, paroxetine, technically an SSRI but unusually anticholinergic for its class. If you see paroxetine, sometimes branded as Paxil, on your list, and you're noticing memory issues, bring it up. Many patients switch to a less anticholinergic option and feel the fog lift in weeks. Fourth, benzodiazepines are stealthy memory erasers when used chronically. Diazepam, lorazepam, clonazepam, alprazolam, they calm anxiety and help sleep because they dial down brain activity broadly. For a short, targeted use in a real crisis, they can be appropriate. But months of daily use trains the brain to be dependent on an outside sedative, fragments deep sleep, weakens attention, and increases fall risk. Tapering must be slow and supervised. Stopping abruptly is dangerous and can trigger withdrawal seizures. If you rely on one now, ask your clinician for a taper roadmap and for replacements that treat the underlying condition. Cognitive behavioral therapy for insomnia or anxiety, non-benzodiazepine strategies for panic, and if medication is needed, safer long-game options that don't trade today's calm for tomorrow's memory. Fifth, Z-drugs marketed for sleep, zolpidem, esopiclone, zaloplan, are not benzodiazepines, but they sit on similar brain receptors. Many people feel less hungover on them compared to the older sleeping pills, and for a brief course after a life event they can be reasonable. The problem starts when a few nights become every night. These drugs fragment deep sleep in some users, worsen nighttime confusion, and leave a residue of attention problems that you may not notice until something important is forgotten. If "I can't sleep without it" sounds familiar, the drug has trained your sleep. The escape route is possible. Cognitive behavioral therapy for insomnia, a structured taper, strict light and caffeine timing, and occasionally a very low-dose melatonin window used as a bridge under guidance. Memory improves when sleep is real, not chemically induced. Sixth, antipsychotics deserve careful respect, particularly in older adults and especially in people with dementia. Haloperidol, risperidone, olanzapine, quetiapine, and similar drugs can be life-saving in severe psychosis or dangerous agitation. They are not casual sleep medications. In dementia, they carry black box warnings for increased risk of death and stroke, and they often worsen apathy and thinking. If they're being used for nighttime restlessness or sundowning, the first step is to ask whether non-drug strategies have been tried. Regular daylight exposure, consistent routines, pain control, toileting schedules, hearing and vision correction, and caregiver coaching. If medication is truly needed for safety, it should be at the lowest effective dose for the shortest duration, with a clear goal and a plan to reassess. Your brain deserves that diligence. Seventh, a family many people don't realize can dull thinking, certain anti-seizure and nerve pain medications. Topiramate is the poster child. It can create a very real word-finding difficulty and dumb fog even at moderate doses. Gabapentin and pregabalin are widely used for nerve pain and sleep. At higher doses, particularly in combination with other sedatives, they can slow reaction time and worsen memory. If you see these in your cabinet and you feel groggy, don't assume age is the villain. Bring dosing and timing to your clinician. Sometimes moving the dose to the evening, trimming the total amount, or switching to topical pain options like lidocaine or capsaicin patches, or to an SNRI like duloxetine for mixed pain syndromes, sharpens thinking without resurrecting pain. Eighth, long-term opioids sap cognition while they sedate. They change sleep architecture, can suppress breathing at night, worsen depression, and often come bundled with other sedatives that together form a perfect storm for falls and confusion. If you are on an opioid for chronic non-cancer pain, you deserve a second look at the plan. Are there non-opioid strategies that could cover some of the ground? Physical therapy, aquatic therapy, anti-inflammatory timing, targeted injections, topical agents, movement practices that you can actually enjoy? Any taper must be slow and kind to your nervous system. Abrupt cuts are cruel and unnecessary. The goal is not to suffer. It's to reduce the fog that keeps you from living your day. Ninth, skeletal muscle relaxants are marketed as, take this for a few days, but they often linger for months in medicine cabinets. Cyclobenzaprine, carisoprodol, methocarbamol, baclofen, They sedate the brain far more than they relax a single tight muscle. And cyclobenzaprine in particular is chemically related to tricyclic antidepressants, which means anticholinergic baggage. If you reach for one at bedtime to knock yourself out, you're trading tomorrow's clarity for tonight's haze. Safer options for spasms after an injury include gentle heat, short courses of anti-inflammatories if your stomach and kidneys allow, stretching, and movement patterns a physical therapist can script to your body. If you recognized one or several of those categories in your cabinet, you're not alone. Most of my older patients have at least 2, sometimes 4. The danger is not just each single pill. It's the additive burden. A little anticholinergic effect from an allergy pill may be tolerable. Add an overactive bladder med, now the burden doubles. Toss in a tricyclic for sleep and a muscle relaxant for the back strain that never ends, and you've quietly built a chemical wall between you and your own memories. That wall is why you lose your keys more, why names float away, why reading a page takes 2 tries. The wall can come down, brick by brick. Here's how to act without panic. Tonight, open the cabinet and write a simple list. Copy the active ingredient, not just the brand name. Put a star next to anything you take most nights or most days. Put a second star if you've ever noticed dry mouth, blurry vision, constipation, confusion, slow urination, or dizziness with it. These are classic anticholinergic clues. Tomorrow, call your clinician or pharmacist and say exactly this. I'm worried about anticholinergic burden and memory. Could we review my medications and look for safer alternatives? I don't want to stop anything abruptly. That single sentence tells any professional that you're serious and reasonable, and it invites teamwork. When you meet, expect a few themes. The first is substitution, swapping a high-burden drug for a lower-burden one in the same category. Diphenhydramine for allergies might become cetirizine or a steroid nasal spray. Doxylamine for sleep might be replaced with CBTI, better light timing, and only if needed a tiny melatonin window for a few weeks. Oxybutynin might become mirabegron with bladder training. The second theme is timing, moving sedating doses to the evening if the day is foggy, or earlier in the evening if mornings are a mess. The third is tapering, a slow staircase down for benzodiazepines, Z-drugs, tricyclics, and opioids. Anxiety about tapering is normal. You taper fear by shrinking it. A small weekly reduction, check in, adjust. I have watched patients who swore they needed a nightly pill reclaim natural sleep over 2 months when we made the daytime calmer, the evening darker, and the habit weaker. You might wonder why I take the tone I do, equal parts urgent and gentle. It's because I've seen the transformation too many times to be casual about it. A man in his late 60s came to clinic with a 10-year fear. My mother had Alzheimer's. I'm losing words. He was on diphenhydramine for sleep, amitriptyline for neuropathy, oxybutynin for bladder, and a muscle relaxant for an old neck injury. No one had ever put the pattern on one page for him. We swapped the allergy pill to a non-sedating choice and worked on sleep timing. We replaced the amitriptyline with a duloxetine plan. We changed the bladder med to mirabegron and taught timed voiding. We retired the muscle relaxant and sent him to a physical therapist who believed in older spines. 3 months later, he walked in brighter. He still misplaced the remote sometimes. He's human. But he could follow a conversation, remember appointments, and laugh about the days he'd forget why he entered a room. That wasn't a miracle. It was subtraction. I also know the objections you might hear, but I've taken this for years. So has your brain, quietly paying the tax. My friend takes it and she's fine. Maybe she is. Maybe her burden is lower, or her genetics are different. We care about you. It's over the counter, it must be safe. Caffeine and alcohol are over the counter. They can wreck a night just the same. My prescriber never mentioned memory. Clinicians manage fires. The long, slow smoke of anticholinergics doesn't always ring alarms in a 7-minute visit. That's why your list, and your voice, matters. If you're still with me, let's build a mini anti-fog toolkit you can start tonight. Get light right. Morning daylight for 15 minutes to set your clock. Low light 2 hours before bed. And darkness or warm dim light the last hour. Move your caffeine earlier. For most people, that means none after lunch. Make dinner a little earlier and a little less salty. Late salt pulls water into the bloodstream and can raise night blood pressure. Walk after dinner for 10 minutes to burn off the day's stress chemistry. Charge your phone outside the bedroom. There is no notification that protects the hippocampus. Set your room cooler, quiet, and boring. If you nap, keep it short, before 3 p.m., and only if you're truly sleepy. These choices won't replace a drug taper, but they will make it easier. I need to say one more protective sentence. Some of you watching are on complex, carefully chosen regimens for epilepsy, severe depression, psychosis, cancer pain, where medication on this list is the right choice for now. You are not broken, and you are not being scolded. The goal is not zero medication. The goal is the lowest cognitive burden that still lets you live your life. If a necessary pill blunts your edge, ask if dose, timing, or a second protective strategy can help. Brain-sparing medicine is a team sport. So when this video ends, do the simplest, bravest thing I ask of patients in my clinic. Open the cabinet and look with new eyes. Read the tiny line that says active ingredient, circle the ones we talked about. Imagine your brain as something worth protecting with the same ferocity you protect your heart. Because it is. Then make the call, ask for a review, say you want to trade fog for clarity. Say you will not stop abruptly, but you won't accept slow decline as the price of convenience either. I will meet you on the other end of that decision with tools, not judgment. If you found yourself in this message, you are not alone and you are not too late. The brain is resilient. When we lift the anticholinergic weight off it, when we swap heavy sedatives for real sleep, when we use bladder tricks instead of brain-numbing pills, when we treat pain without turning off cognition, the brain thanks us with sharper mornings and steadier afternoons. People laugh more when they can think clearly. They fight less with loved ones. They drive more safely. They learn a new recipe. They remember grandchildren's names without rehearsing. That's not a small outcome. That's your life. I'll close the way I began. Never stop a medication by yourself. Bring your list, your questions, and your hope to someone who can help you plan. If your clinician isn't familiar with anticholinergic burden, ask your pharmacist to join the review. Pharmacists are masters at this. If you feel dismissed, seek a second opinion. Kindly, persistently. Your cabinet is full of decisions you made at different times of your life for different problems. Today is simply a day to update those decisions with what you know now. That's not failure, that's wisdom. When you're ready, check your cabinet. 9 families to look for. First-generation antihistamines and PM sleep aids, overactive bladder antimuscarinics, tricyclic antidepressants, and the anticholinergic SSRI paroxetine, benzodiazepines, Z-drugs for sleep, antipsychotics outside of strict indications, certain anti-seizure and nerve pain drugs like topiramate and high-dose gabapentin or pregabalin, long-term opioids, and skeletal muscle relaxants. Replace panic with partnership. Replace fog with clarity. Replace, I guess this is aging, with my brain is worth protecting. Your memories are not disposable. Guard them the way you guard the people in them.